Hey, everybody, welcome back to Radiology Rewired. I'm your host, Dr. Singh. Today, we're going to be talking about AI ripple, as in what is happening in healthcare as a whole outside of radiology, and how is artificial intelligence affecting all the different specialties and why that's important for you. We'll talk about how integration of artificial intelligence, especially in clinical specialties, requires administrative oversight and how multiple different departments have to work together to get these systems working. We're also going to be talking to a chief medical officer of a large hospital system who's going to provide some really valuable insight into how AI algorithms are adapted and evaluated from the hospital standpoint in terms of return on investment. So we have two articles to discuss today, really short, but basically the first one is from Nature, talking about the effects of AI implementation on efficiency in medical imaging. What they found was that two-thirds of these AIs are showing actual efficiency improvements. However, only 3 of the 47 studies performed show that there was a positive return on investment for these hospital systems. This becomes really important in determining whether a hospital is going to continue to pay for a service. All these artificial intelligence companies are going to charge a monthly subscription fee. It has to make sense for the hospital to pay those fees, and we need to see it translate to better outcomes for their patients and return on investment. The second article that we're going to talk about is from the Financial Times, titled Doctors Pioneering the Use of AI to Improve Outcomes. This article highlights the cross specialty communication that is imperative to make an AI algorithm work. We talked about this with thrombectomy, about coordination between neurosurgery, neurology, and radiology. Like we talked about with these mobile outputs, it really doesn't help if only radiology has access to the information. It must be shared among the departments, and licenses should be paid for so that the people taking care of this patient are all aware and getting the same information. Unfortunately, this requires a really supportive administration that strongly favors artificial intelligence and is willing to spend that money. We found through these studies that the ones that actually do have the best success and the best results with artificial intelligence improving their clinical workflow, and those who lack that integration across specialties do not see the same benefit. So, really important to have a supportive admin that is all about artificial intelligence and improving care.
All right, guys, we're moving on to the interview portion of this episode today. I've got a great guest for you, Dr. Samir Kumar, who is a CMO has served at a couple different hospital systems in Chicago. Dr. Kumar, so thank you for joining us. So I wanted to touch base a little bit about your journey and how you went from like a clinician as a nephrologist to becoming an admin, and then wanted to kind of touch about how AI is being integrated in the clinical workflow. So just please start and tell me about yourself.
Sure. So I finished my fellowship in 2003. And for the first few years, I was just a regular nephrologist minding my own business and clinical care. And then I started to get involved in a few committees. It started off with pharmacy and therapeutics. And then I found that, unlike a lot of my colleagues, I actually enjoyed the work of kind of being a step behind the scenes and managing quality and patient safety, not necessarily at the individual patient level, but at more at the hospital level across a broader population. And once I found I enjoyed it, it became a passion of mine. And I gradually advanced my career through advanced training. I got an MBA. I took progressive roles within the hospitalization and became eventually president of medical staff. And then in 2019, I had the opportunity to become CMO and interviewed for a job, got the job, and kind of since then, that's what I've been doing for the past 6 years. So it's been fantastic. With regard to artificial intelligence, it's a great question. I think right now we're seeing a lot of AI applications in spaces like coding. We have AI applications that screen charts and provide suggested codes much more efficiently and at a lower cost than a human could. We're seeing them in clinical documentation, integrity projects, and stuff like that. But what fascinates me is not necessarily those areas, but areas where we can improve clinical care. So, for example, clinical documentation or clinical decision support, I should say, is an area that we have a tremendous potential with AI solutions. We're also using it to reduce physician burnout. So the ambient listening platforms are helping our providers complete all of their documentation on time. I mean, it was so bad our industry had a term for it. We called it pajama time, where doctors were spending all this time late evenings just completing their notes, on what should have been their personal time, time that they should be spending with their families. And we've improved that. And if you think about, the burnout effect in healthcare for our providers, I think that's a huge solution. But for me, the great promise for the future is in clinical decision support, where we can use AI tools to make critical thinking decisions that providers have to supervise and provide input on. But a lot of the decision making can be done through sophisticated AI models.
Yeah, that's great. And we had talked, off the show, but I brought up the article recently from UCSD about these new predictive models that are coming out, where they're looking at all these different parameters. In particular, over there, they looked at about 150 parameters in terms of predicting sepsis. And you had mentioned something similar. Can you tell me about these other predictive models that you've seen so far?
Oh, absolutely. So we used one, and honestly, that was a game changing moment for me in healthcare. So let's think about it a little bit. When we, if I take a stethoscope and listen to a murmur, I get some information, but no matter how good I am, I'm not going to be able to get the information that an echocardiogram will get. And if I palpate an abdomen, I'm simply not going to get the information that a CT scan of the abdomen will get. But for me, those are extensions of, you know, limitations in my physical capacity, if you will. But when I saw some of the predictive algorithms work, for the first time, I saw how critical thinking was done better than a human. And we used a similar model to what you've described when I was at Ascension. And it looked at over 90 variables to predict which patients who are hospitalized were likely to decompensate in the next 24 hours. And so, in addition to what we're normally used to, like pulse and blood pressure and pulse oximetry and stuff like that, it looked at hemoglobin and bilirubin and creatinine and just changes in blood pressure variability and heart rate variability, and was able to predict patients who are going to decompensate. And I remember walking into the rooms of these patients, and they looked fine. They looked great, and yet you had this algorithm that was able to figure out stuff that we couldn't figure out. And it dawned on me then that this is gonna fundamentally change, the way we practice medicine. We now have technology tools at our disposal that can do this job better than we can. Now, we still need physicians to supervise this. It's obviously not 100% accurate, it has errors, um, but it does a phenomenal job, and in many cases, it does a job better than the humans currently can do. And that's something we need to consider. We need to look at the ability for critical thinking to be done by artificial intelligence. And I think the program that you mentioned had data showing that it cut mortality.
Right. Yeah. 17% reduction in sepsis mortality, which is
If you think sepsis is still a leading cause of death for hospitalized patients, so 17% reduction in mortality, even in absolute numbers, is phenomenal across the scope of the country. And you know, um, similarly, these kind of solutions for hospital-based, there's a lot of data from the IOM about mortality related to healthcare and opportunities. And if we can recognize these patients sooner and get to them sooner through algorithms like this, we're going to save a lot of lives in healthcare.
yeah, no, it's really exciting, and I was really interested to hear. You had mentioned, I think scheduling is a big problem in medicine and healthcare. Getting appointments and things like that, and even getting beds in the hospital, right? Like people getting readmitted and like trying to figure out the length of stay. So, you had mentioned about surgery OR time and how there are these new models that can predict, when the OR is going to open back up, so you can do more surgeries in a day. Can you talk a little bit more about that?
Sure. So, the most expensive real estate in the hospital and the most expensive time in the hospital is within the OR. There's all kind of data of what a minute in the OR costs, and so, optimizing the OR specifically, but in general, procedural areas in the hospital is something that we administrators look at very, very closely. And the OR, in a sense, is kind of like, booking a hotel or booking a flight. You have to predict how many cancellations and no-shows there are gonna be, and so you kinda overbook a little bit. That's what's routinely done in the hotel industry or the airline industry. The stakes are a lot higher, I think, in the OR space. It's a very complex environment. Um, the traditional model has been, you have block time, you have an OR day, it looks like it's full, but then you have cancellations, you have surgeons who are on vacation and release their block and you can't fill it. And there are very sophisticated AI tools now that can help predict, in the beginning of the week versus the middle of the week, how much OR time is gonna be available based on the month of the year, based even on the temperature outside. What are gonna be cancellation rates based on, historically when physicians take vacation or, things like that. And these sophisticated models can do a much better job than our OR schedulers in predicting availability. And by using some of these AI tools, we're able to optimize OR efficiency, make sure our OR times are filled. If OR is available, to rapidly get those times filled by pushing out OR availability on electronic platforms to surgeons' offices, things like that. And these solutions, even if you can increase by 5% or 7% your OR utilization, it translates into millions and millions of dollars at the end of the year for an average sized hospital. So these are incredibly important solutions.
So one of the biggest, I think, conflicts between these smaller AI startups is the fact that you have these big clinical platforms that are already integrated in a lot of hospitals that are trying to do a lot of the same thing. Um, how do you see this playing out? Do you think, these big EHRs are going to kind of be the one driving the force for the AI integration, or do you see room for other players to get involved somehow?
I think the large EHRs are going to have a lot of say in this space. And the reason I say that is from the perspective I sit from a large integrated delivery network, large health system, there are two big concerns we have. One is we may have a very good individual AI solution, but it's an isolated solution. And you can only go so far when you piecemeal multiple solutions into your network. And so a lot of times we're looking for integrated solutions as opposed to, a single point solution, no matter how good it is. The second is the integration costs. Every time you're trying to interface new technology, there's an IT cost that's associated with that. The cost can be quite staggering. And even if you're willing to pay the cost, sometimes just the availability of IT support within your health system, that project could be put off by 6 months or a year just to integrate the product. And then finally, one of the concerns that's really exploded in the last couple of years has been around cybersecurity. Um, I was at Ascension when we had a major cybersecurity event, and I certainly can't speak much to the details of the event, but I think it's pretty fair knowledge to say that it was disruptive. I think we handled it very well at Ascension, but it was disruptive, and healthcare systems simply can't afford a major cybersecurity attack. So for integrated delivery networks, the ability to say, hey, I'm going to deal with Epic or Cerner, and they're going to handle these flows. They're going to integrate these technologies. And if they're homegrown technologies or somebody that those vendors are partnering with, then that becomes an attractive solution to me as a large health system. So I do think that for some smaller independent vendors, this may even be an existential threat that the large EHRs may develop their own solutions that could take over. And that's something I think we're going to see more and more of in the next 5 to 10 years. On the other hand, vendors that have very unique capabilities that are going to be hard to replicate, even by well capitalized companies like Oracle or Epic, I think those entities will survive and thrive in this environment.
Yeah, and I think we've seen that in radiology as well, where I think people spend so much time trying to get a new tool integrated And then they run into bumps down the road with it, not functioning as it should because it wasn't integrated. And now I think some of the, companies are producing like cloud-based solutions where they can add on different vendors into their kind of cloud platform so it runs seamlessly. I don't know if that's something maybe that they'll do, but it seems like from my perspective that a lot like Epic in particular, they're just going to develop their own in-house stuff. They're not going to rely on anybody to just tack on to their thing.
Yeah, I think that's 100% correct. Now, a lot of the AI platforms in imaging, they have a great deal of depth to their technology and what they have done, that I think it'll be much harder for some of the large EHR systems to replicate that. Now, they may choose specific partners that they partner with, but I think it will be hard for them to replicate that, um, even though they are very well capitalized companies with a huge workforce. That said, the ability as a healthcare system to partner with a vendor who, has a cloud-based platform that can integrate multiple solutions within it, is certainly much more attractive than a single point solution kind of a platform.
Yeah. Yeah, for sure. And in your perspective, as coming from administration, I think you're going to have the best view about how administration and hospitals evaluate newly deployed artificial intelligences. So, we talked today in this episode a little bit about articles looking at what the actual return on investment is. They looked at about, like a bunch of different hospital sites, and only like 3 out of the 47 places even had a little bit of demonstrable return on investment when they looked at the numbers. So, how are you guys evaluating whether you're going to stick to an AI solution or not? Like, what metrics are most important to hospitals?
Sure. I think, before I answer that question, I'd like to maybe share with you a study we did at Ascension, which looked at return on investment and is still one of the better examples of, looking at return on investment within the AI space as far as imaging goes. So, what we did is we looked at 3 years of data with over 1,700 stroke claims across a single hospital. And we looked at return on investment based on, how many more mechanical thrombectomy procedures did we do? Did we reduce length of stay, staff time, and reduction in complications? And we compared it with our own historical data. And we found that our door to mechanical thrombectomy time reduced by half an hour, a solid 30 minutes, with the introduction of rapid AI, which is one of the solutions out there. Um, we also saw a 51% increase in our mechanical thrombectomy procedures. And so there's certainly a financial impact to that, but probably more importantly, much more importantly, we brought the therapy that patients needed to them that were previously not getting that particular therapy. They may have been candidates for thrombolytic therapy, but the ideal therapy is mechanical thrombectomy based on the lesions that they had, and we were able to get them that therapy. When you have these solutions in place, you can get patients to the right destination faster. I think it really helps when you're in this hub and spoke model and you're trying to get patients to comprehensive stroke centers so they can get the care they need. But you also don't want to overburden your comprehensive stroke patients with patients who could have been taken care of at the peripheral hospital. And so, you know, all of this translates into real money. Some of it is hard dollars, some of it is soft dollars, but these are real dollars. And in our example, we saw a $4.5 million positive return on investment over the span of 3 years, looking at this data.
Wow. Yeah, that's really impressive. And I think one of the recurring things that we've seen is that thrombectomy, door to thrombectomy time and AI solutions for that's a moving the needle solution. Like you mentioned, you're actually getting your investment. You are treating patients quicker. Communication is improved between the clinical teams for these software solutions. What do you think is going to be the next like moving the needle AI technology that's going to affect the greater clinical landscape, not just radiology, but what do you see as like the thing that's going to be coming out soon? AI isn't just assisting anymore, it's anticipating. Rapid AI is leading the next wave of innovation, transforming imaging insights into predictive and prescriptive intelligence. From uncovering critical incidentals to helping clinicians anticipate patient trajectories, Rapid AI bridges the gap between research and real world care. Built on deep clinical validation and trusted by the world's top hospitals, Rapid AI is defining what comes next in healthcare.
Yeah, I believe that we have to move our mindset from AI solutions, from being a vendor trying to sell an AI technology to a paradigm where we are partners with a healthcare system to develop a clinical solution across the workflow for that condition. And so within the space of, um, say, stroke or neuroimaging, for example, yes, the technology can improve the accuracy of reads and help us pick up on, the area at risk, the brain tissue at risk or where the lesion is. But it's also helping us get to patients faster by pushing solutions out to a neurologist maybe who's sleeping at home, who can, instead of logging into PACS, is just looking on their phone and accessing this information. So we're able to make decisions quickly. And so what that did, for example, in our health system is we were able to move to an auto accept policy for strokes with large vessel occlusions because our radiologists, neurointerventionalists were able to look at these literally in real time. So we were able to get patients moving to the right destination. And so for me, it's a paradigm shift. It's across the patient journey, we can improve, um, whether it's outcomes, whether it's safety, whether it's, less burden to our providers, whether it's saving time, all of these solutions through our vendor partners. And then it's not a static solution. The technology evolves and develops. Stroke care changes with time. There are new guidelines. And what we are looking for from the integrated delivery network perspective is who's going to be a partner with us to help us grow our programs, to help us continue to provide solutions, to constantly improve our workflows, not just sell us a solution and give us software upgrades periodically and stuff like that, but to be a partner with us as we solve this clinical problem. And I think that's the next wave. I think we're going to see a lot of innovation around clinical decision support in the next 5 years. Just imagine if your hospitalist shows up and, instead of just printing their 20 patient work queue and going in one by one, their AI chatbot says, "Hey, I'd recommend seeing the patient in 4053 first because their hemoglobin dropped from 8 to 6, their blood pressure changed by this much, and, we're predicting this patient is having active GI bleeding starting overnight." And you're like, "Wow, that was the last patient I was gonna see today." And, I didn't get a call from nursing, so I'm really glad. And those solutions are not far away from being, clinically available to us. We can streamline workflow to where suggested therapeutic interventions are available to us. Right now, we have some of that in its fledgling stages. For example, in pharmacy, you order a medication and you'll get a little pop-up suggesting a dose change or a substitution. But this is next level intervention, right? And the technology will continue to improve. Right now, the AI is still going to have some mistakes. It's still going to not interpret all the information correctly or have all the studies accurately associated with the individual patient. But it's a great starting point, and it frees up our providers to do what they really need to do, which is the highly critical work. It also will free up providers to do what they've been taken away from, which is direct patient care. Spending time in front of the patient instead of the computer and being that empathetic listener so that our patients feel like their care is better and more human than it is now. And I think um, clinical decision support tools for our providers, not just in the fields of oncology or cardiology, but across the board is really, I think, the great promise that AI will deliver in the next 5 to 10 years.
Yeah, that's really exciting. And I think kind of mirrors a lot of the tools in radiology and what we hope will happen if you get something that is looking through your scan, like highlighting findings, measuring things for you, and then giving you a pre-populated report that you can then just put into context of the patient, look at things clinically, and actually communicate and provide some real value that way. Whereas, right now everybody's just kind of burning through, and I think it's the same way on the clinical side, and everyone's burning out.
100%. And I can tell you right now from the administrative side, and as a radiologist, you probably agree, radiologists aren't falling off trees right now. I mean, it's hard to find radiology coverage. And the last thing we need is for our highly trained radiologist to be sitting there and trying to measure a small aneurysm in 10 different ways, or an artery or some other structure in 10 different ways. We would like to see our radiologists really focus on the important things. And if your time is spent reading a bunch of normal studies, and then, doing work that is not top of license when you're reading some of the important studies, then you're not providing the greatest value that you can provide. And if a lot of that work is taken up, or taken over, I should say, by our AI solutions, then it allows you to focus on the most important things, provide that critical information that we really need, and now you actually have the time to get to the important studies on time, so that there's no delays. You actually have the time to pick up the phone and communicate with an emergency department provider, a neurosurgeon, or a critical physician, maybe a trauma surgeon, about an important finding. And you can do so and just have that human to human communication that's not pressured for time, because you're not sitting on 150 more studies that need to be read. And so I think that's another great promise of AI, is to allow our providers to do what they need to do without the constant stress of backlog. And this is true not just in the radiology space, right? We don't have enough primary care providers, in this country. And we're going to have to find solutions, to help ease the burden so that our patients still have access to high quality care. Physician extenders is certainly one way to do that, through advanced practice providers. But technology-based solutions is another way to do that. And the technology-based solutions, which will incorporate AI, has a huge promise, to help our overburdened primary care providers really function at top of license, see the most critically ill patients, spend time with patients, make the decisions they should be making, and not be spending time on work that they don't have to.
Yeah, I'm glad you brought up primary care. One of our other guests, Dr. Height, was talking about how, if you had an artificial intelligence solution, like we'll just say for primary care, one of their main jobs is pointing out like the sick person in the, 20, 30 people they see, having that expertise to find out like, hey, this one is actually not doing well, whereas these other 19 people are doing fine. His point was, hey, what if you had this, like we're talking about clinical parameters, this AI that's running in the background, looking at all your patients' lab values, combining it with all their imaging stuff, and then giving that family medicine an assessment for his patients throughout the whole day of who is more likely to be sick and things like that. Like you can see how that's going to be a lot more valuable, like to the primary care provider. Do you see that maybe happening down the road?
I certainly hope so. I think, what would be even better? Let's say the AI algorithm predicts that on a a patient list that the physician is supposed to see that day. What if it could then automatically increase the appointment times for those patients, right? So it's all happening in the background, and, suddenly you're not addressing that super sick patient in a 15-minute time slot. It got adjusted to a 30-minute time slot so that you can actually address the complex issues that would help take care of that patient. And really, the technology, everything we need to achieve this goal is there today. The large language models and everything don't need to get any better to get there. We just have to develop the solutions. We have to develop it to where it can be implemented in the sharp end of care. But we have all the knowledge we need to do that. Someone just has to build an effective model, and they're probably already doing it, and I just don't know about it. My sincere hope is within the next 3 to 5 years, we have solutions like that available to our doctors. They go into their office, they check in, and they automatically know who are the patients they need to spend time with. A lot of routine prescription refill tasks and other tasks are automated and made simple for them. They still have to sign off on them, but it's just not a burdensome task anymore. So those few patients who are really sick, they can truly, spend the time they need. I was reading about an AI algorithm that was used in the United Kingdom, which predicted based on a bunch of input parameters, which patients would require to go to the hospital versus stay at home when the EMS was called. So when the EMS is called right now, it's an EMS provider sometimes making a decision about who they transport to the hospital and who they don't. And an AI algorithm was surprisingly good at predicting who needs to go to the hospital. And, solutions like that are a classic example of how we can impact lives very quickly with the appropriate use of AI.
It seems so complex to evaluate how much value an AI tool is bringing. You talked about some of the parameters that the hospital looks at. In terms of you're always paying this licensing fee or this subscription fee, and these can be really expensive depending on the AI platform you're using. How long do you guys evaluate and weigh the pros and cons of a new AI deployment? And I guess like, my question is like, what is the main parameter? I guess it's going to be dependent on what kind of AI solution it is, but I'm just wondering, how do you figure that out when you're trying to assess if you're going to keep this thing or not?
Sure. So, the parameters I think we would look at are, quality and patient safety. So it's got either improve quality or at least be quality neutral at a minimum. The second would be, a financial, so a return on investment. And those can be in terms of hard dollars or soft dollars. Um, it obviously has to meet certain compliance regulatory guidelines. We would want to know if it's going to bring about operational efficiency. Sometimes, it may not be inherently less expensive. In fact, it may even add a little bit of cost, and it might not be inherently clinically superior, but it might help you build capacity. It might help you solve for a staffing problem. An example I came across recently was with Rapid AI, and they have a new solution that does 3D reconstruction and saves time for CT technologists who were previously doing the work. And we have a shortage of CT technologists. We often have to hire agency CT technologists at triple the rate just to fill staffing gaps. And so sometimes the solution may be just to solve for staffing or operational concerns and things like that. So I think those are some of the things we look at. Within the specific ROI kind of space, that's a tough question. I think the time horizon in healthcare is shorter than in a lot of other industries, and we're looking for a return on investment, I think, within 12 to 18 months. We really it's very hard to justify an investment that's gonna return, um, that's gonna be positive as far as an ROI goes in 3 to 5 years, within the healthcare space. So I think, we have to see some kind of return on investment fairly quickly, either through increased volume, a reduction in expenses, etcetera. The exception to that is, I think, when you start to see, a compelling quality case. I think then we can ignore the ROI equation, and we're actually willing to spend money if we know it's gonna bring about a better outcome for our patients. So I think those are some of the things we look at. From a decision-making perspective also, there's been a change. I think a lot of these solutions were sold at the hospital level in the past, so vendors would go out and connect with directors of imaging services or a few key doctors, and they'd bring the solutions up to the CFO or COO at the hospital level, and the hospital would make the investment. Um, More and more nowadays, the hospitals are not making these decisions at the hospital level. These are being made at the enterprise level. And I think there's two important players that come into the picture here. One is service lines. So more and more large health systems are moving to service line models to make these decisions. So you have an oncology service line, an orthopedic service line, a neuroscience service line, a cardiology service line. Um, and these decisions are being deferred to the service line to make appropriate decisions about the technology solutions. The second important player are AI governance teams. And I think more and more large health systems are putting together teams that have sometimes even a dedicated AI specialist, or if not, the CMIO or some high technology person, CTO within the organization, who is leading the AI efforts. And usually there's at least one or two clinicians involved in that, oftentimes a patient safety or quality advocate, somebody from legal, compliance, regulatory, et cetera, to work on a multidisciplinary team that reviews finance will probably be there, that reviews AI solutions and make sure that we're ticking all the boxes in terms of evaluating AI solutions, particularly the larger AI solutions that are going to be deployed enterprise-wide. These small onesie, twosie solutions, I think, may not rise to that level, but I think some of the broader AI solutions, kind of go through these governance committees. That has not been the traditional model in the past, but more and more large health systems are moving to that model. When they do so, I think they will evaluate all of the things we've talked about. For me, it's always been quality and patient safety as number one, and then operational efficiencies and, the financial return on investment as number two. I always like to ask the question, what problem are we solving? Is it clear to me what problem this solution is going to solve? And if it's not clear to me, if it's kind of nebulous and just out there, I'm very hesitant to move forward with that solution. I also want to know, what does the future look like? It's not a static decision. It's a decision that we have to look, far out. And the best solution today may not be the best solution for tomorrow. The second or third best solution today, if it integrates well with our system and, is a well-capitalized team that we feel will grow with us and is going to be there 3 years from now, you know, um, to enhance the care that we deliver, we may partner with them even if they're not the best solution today. So I think these are some of the added considerations that we would take into consideration.
That was a great explanation that clarifies so much for me. So a lot of these decisions are made like kind of on a multidisciplinary team. You guys weigh the pros and cons. Maybe the finance people are more worried about the finance stuff and you're more worried about the safety and quality stuff. Who do you guys provide a recommendation? And then who is the one who's like, yeah, we're going to go with this one?
So a lot of times, depending on the scale of the solution, it could be a very high level that there's final approval. I can tell you that for most major solutions, that is not happening at the hospital level right now. It's either an enterprise level or at least market level executive, typically a chief operating officer for a market or system, chief financial officer for a market or system, or maybe even the CEO of that market that's doing it. So, for large integrated delivery networks, typically the decision making rests at that level for some of these very large solutions. For, I think, a vendor who's, looking at a contract of 50,000 to $100,000 a year for a smaller scale solution, you might see a hospital CEO make the decision, or maybe somebody in a service line make that decision. It may still require a sign off from the CFO, but that's probably going to be much more routine than an in-depth evaluation by the CFO, for those kind of decisions. So I think it depends on the scale of the solution, but more and more you're finding that those are taken out of the hospital and are being handled at a market or enterprise level.
And as these AI tools continue to develop and we become essentially more reliant on them, are you worried about the, clinical prowess of new doctors coming out of training, where they're just so reliant on AI? Even radiologists, for example, not having that, straight search pattern because it's already done and they have this pre-populated report. How do you solve for this and like all these new AI solutions that are coming out?
I think that's a great question. And I think we know it's coming. And so we have to adapt to that. When I trained, I took blood pressures all the time. And as a nephrologist, I was board certified in hypertension. But, I don't take blood pressures anymore. A nurse is going to take a lot more accurate blood pressure than I can, despite my knowledge, expertise in the field. And so I think we have to adapt to that. I think it's very, very real. There's already studies about this in the endoscopy literature and stuff like that. And I think what we really need to do is understand how best to train residents and fellows to be conversant and comfortable with AI while simultaneously retaining their core skills. Um, and not only that, but when physicians are out in practice, how do they maintain competency? And that's something we're going to have to figure out as a society, as a group of physicians. You have a lot of physicians nowadays who come out of surgery training and they've done almost all of their training on the robot, and they're just not as comfortable with open cases anymore. And they do open cases sometimes, but they're just not as comfortable as physicians who, you look at some of the real old time surgeons and they did a lot of these complex gastric cases before proton pump inhibitors were around and before H. pylori was discovered and Bill Roth 1, Bill Roth 2, and all these cases that for years surgeons never did. And then some of those procedures staged a little bit of a comeback, when the weight loss industry took off. But for the most part, you know, it's one of those things that we as a physician group have to internally solve. You don't have to do a ton of cases to be competent, but you certainly have to maintain your skills. And that's a great question. I don't have a good answer. But what I will say is it's up to us as a physician community to design those solutions rather than ignore the problem and expect that a solution will magically pop up. We have to be very intentional about how we look at it going forward.
Yeah. I love this discussion so far. I think we've touched on a lot of different clinical pathways in medicine and how they're being affected. One thing I wanted to touch base about is the NPs and the advanced practitioner providers with it augmentation from AI. How do you see that playing out in terms of like the already, shortage of physicians and kind of rise of these mid-level providers? Do you see some world where, the physician's role becomes even more just, hierarchical, like where they're just kind of overseeing a bunch of people with these AI bots and things like that? Or how do you see that playing out?
With decades of clinical experience behind them, Rapid AI is transforming how imaging and clinical data come together to help care teams make faster, more confident decisions. Their technology is helping hospitals move from reactive care to proactive care, all built on a foundation of clinical validation and real world impact. The future of medicine isn't just intelligent, it's rapid. Learn more at rapidai.com.
It's interesting. I think it will vary by field, but I do think more and more physicians will be limited to the really complex work. Whether you're an oncologist or a cardiologist, if you're an interventional cardiologist, you're going to spend a lot of time in the lab and a lot less time, doing lesser value work. I'm not saying the work doesn't have value, but it's work that could be done by somebody else while you're in the lab doing the critical procedures. I think we're going to start seeing that, as we've briefly discussed, even, in the primary care space. The primary care physicians are going to start spending their time with the sickest of patients. Let's go through an example. Let's say I see a patient with complex hypertension for the first time, continue with the hypertension example. And I go through my diagnostic, list and I order a bunch of tests to see if they have maybe adrenal gland disorders or, something of that nature. And then those tests are back and I discuss it the next visit with the patient. The blood pressure is already trending better with medications. The important results are back. And now office visit number 3 is for just, regular hypertension management at this point. You just can't give me a good reason why I need to see that patient. That patient should absolutely be managed by an advanced practice provider, and with or without an AI solution to guide them. And, the physician is always available for consultation, but it will allow the providers to focus on, I think, the sickest patients, the patients they really need to be with. You know, I think there's a big fear that AI will take over the jobs of healthcare providers and physicians in particular. Um, and while I think that will happen to a degree, I don't think that's really what's going to happen. I think AI is going to augment providers and make providers better at what they do by sharpening their focus and taking some of the lower value tasks away from them. It will allow physicians to have more time for themselves, for their families, to reduce some of the burnout that we feel. Most physicians don't burn out doing high value work. They burn out because of low value work they don't see um, as engaging or interesting. Direct patient care almost never burns anyone out. It's the paperwork, it's everything else. The more we use solutions to help with the lower value work, then it allows us to be better clinicians. And I think the real promise of AI is to help physicians be better versions of themselves, help them get more time back, sharpen their focus, spend more time with patients face to face. And so I think this is going to be a net plus. And I've approached this question from the provider perspective, but honestly, the most important thing is it's probably going to enhance patient care. In the long run, it will make care better for patients. As good as we are, and the human brain is a remarkable thing, but we are at the end of the day subject to fatigue. We're subject to stress. We're subject to burnout. We have biases that are built into our system, and all of these affect our clinical decision making in subtle ways. Nobody goes out with the intention of making bad decisions or missing findings or making errors. Um, but it's just a part of what happens in the regular flow of things. I've done that when I'm tired and I've been on call and awake at night. I'm just not as sharp as I should be. And this is where AI solutions can help us be better. So I think there's tremendous, promise in this space. That having been said, I do think some physicians will lose their jobs.
Yeah.
But I think the greatest benefit will be to physicians uh, in order to get some time back and enhance their quality of life.
Yeah, I mean, you think about your example of like a primary care doctor maybe having a couple APPs, and then now the APPs are much more efficient and are confident in seeing patients, and have this AI helping them out to screen for all these parameters, making sure this patient isn't going downhill. They can probably see a lot more people that are generally healthy, and like you said, that family physician can focus on these sick patients, but that might be 4 or 5 patients per day. You don't need as many of them around to get through that workload anymore. So is that kind of where you see it happening, where you just need less people?
I think you might need less people, and then the people you have, as we've talked about, can spend more time, maybe go home a little bit earlier, have better quality of life. Um, my gut feeling is there probably won't be wide scale replacement of physicians with AI. I think what'll happen is, we're going to see this physician shortage ease up a little bit because we'll have the ability to use AI solutions effectively, and allow our physicians to take care of a larger number of patients more effectively, and thereby kind of alleviate some of the physician shortage. But I don't think you're going to see a lot of physicians not have jobs. I don't think that's, just a little bit of history. 1997 Balanced Budget Act effectively froze the number of physicians entering the workforce at around 100,000, give or take. Let's go with 100,000 as a round number. Um, because of the way Medicare funded residency programs. And since then, that's kind of been the bottleneck of the number of physicians entering the workforce. Meanwhile, the population of the United States has gone up 25, 30%, while the number of physicians entering the workforce has stayed stagnant. Couple that with the fact that, in and around COVID and after, the number of physicians exiting the workforce has accelerated. So there is a genuine shortage of physicians, and it's not one that we can, quickly solve for. So we need AI solutions. We need physician extenders to help us solve this problem. It's a very real problem. There have recently been some legislative changes which have allowed a few more residency programs to, be funded through Medicare and stuff like that. But for the most part, that bottleneck you can open as many medical schools as you want. the residencies is the bottleneck to physicians entering the workforce. And so I think that's a problem that will be solved to some degree by AI. I'm not going to suggest that AI will completely solve it. So I think what we're going to see is more solving that physician shortage problem than physicians actually not having jobs. I think that's probably more fear than anything else.
Yeah. And we talked a little bit on a couple episodes ago. We were discussing certain AI algorithms. Like, let's say you have an AI algorithm that is very sensitive in screening negative mammograms. Like, these are all negative. You don't have to even look at these, and they just put them away. Okay. Do you think that there's gonna be a time where we have a almost like, "Oh, you're healthy" AI type thing where it looks at all your lab values, it looks at your vitals, and then it's like, "You don't need to see a PCP, you're good, just continue doing this and this," and you reduce the number of patients that have to be seen by a doctor. Do you think that's gonna happen?
That's a great question. So I presume the AI won't be doing a physical exam. However, let's be completely honest. What is the value of a physical exam in somebody who's at low risk for problems and already has a normal set of screening labs? It's probably not great. There's probably some utility. Maybe we could move instead of an annual physical to a physical every 3 years, who knows? But, I think, that's a great opportunity for ongoing research. At the end of the day, um, almost all of our clinical decision making, we're playing the probability game, right? And so if the probability of finding something with an annual wellness visit is below a certain percentage point for a patient that meets the description that you described, then maybe our recommendations will be you don't need to see someone. That's not saying there's no chance of an abnormality, but it's so low that it's probably not worth it. And we'd move to an annual visit maybe every 3 or 5 years or something like that. So I think that's a potential solution. I'm purely speculating here, but I think the research, we can do studies to help us decide what's the most appropriate way, to handle those patients for sure.
How do you think large scale adoption of like clinical AI is going to improve access to healthcare in more remote or rural areas? Because I think that's still a big problem being able to see a specialist. So, do you see any role of AI really improving that?
Yes, I absolutely do, and some of it may not even be as complex as highly sophisticated AI. Some of it may simply be remote technology. So um, if you have access to some basic technology, you could be on a farm in the middle of Idaho or Montana or New Mexico and get access to a specialist at the Mayo Clinic or the Cleveland Clinic or a top-notch institution. That provider may not be able to do a physical examination, but they may be able to do just about everything else, and they may have aspects of the physical examination available to them. We can do very good, auscultative examinations remotely of the cardiovascular system. We can, check blood pressures and heart rates and do EKG and everything remotely now, all through pretty accurate wearable technology and things like that. And so a lot of the information is there. And if you have an advanced practice provider there, they can do a good physical examination and convey the findings to you. So, you've taken that distance aspect away. In the imaging space, as you know fully well, you can take a plain CT scan now at a hospital that may not have access to an MRI or more advanced technology. And using the AI applications, we can glean a lot of information even from a non-contrast CT scan. And so, more and more we can do that. In fact, that's almost the biggest short-term promise of some of the AI solutions. It may not change a lot for the patient who's at a big tertiary care center at 10 a.m., but it may change something for someone at a rural hospital or someone from a community hospital at 2 a.m., where they may have great care during the day, but it's not 24/7, 365. At night, they may not have access to a neuroradiologist. They may not have access to a gastroenterologist or somebody, but through remote technology, telemedicine, virtual visits, we might be able to provide excellent care to these patients We may still need to transfer some of them, but many of them can stay at their destination, at their location without requiring transfer to a tertiary care hospital, which is disruptive for patients, when it's not necessary. Can you imagine driving 100 miles from a rural hospital or a rural location, and incurring an ambulance fee that could run into the thousands? For something that turns out to be, completely nothing. Yet that's happening every day across the United States, and technology and AI solutions are out there to help prevent some of that.
Yeah. And you touched up a little bit about how these new modules are coming out to reduce like reconstruction times in CT techs, for example, like the amount of time they're doing this arduous task of just drawing lines through vessels while the patient's still on the scanner. You're like delaying scans. The other thing is with scheduling in AI, I think like there's a lot of room to improve efficiency with no shows and predicting cancellations and filling those spots. Have you seen any of that yet? Is AI scheduling a thing in your department, or have you seen it?
We haven't broadly adopted it across primary care and several areas within the hospital, but we are seeing more and more AI solutions. We've implemented it in the OR space, but we're start looking to expand those solutions because that is, an ongoing problem for us. And the solutions currently available are actually quite good, and they can do a lot of that work. In transitions of care, you know, we still, even in 2025, had a lot of siloed care. We have patients who leave acute care facilities that are transitioning back to their primary care physician. And, the old fashioned way, we send over a fax machine a sheaf this thick of, hospital, the discharge summary, the chart copy, if you want to call it that. And which primary care provider, when they have 25 patients on their list, is going to go through this thing and, notes that are copy and paste and are not conveying, we just need a better way. The AI solutions and technology can do some of that work. We now have the ability to just synthesize a short note. We can look through reams of information, synthesize important note. They need to know the discharge diagnosis, any important follow-ups, what the current medication plan is, the medication reconciliation at discharge and how it differs. What are the important labs to follow up on? Things like that. And that's the important things that they need to know. Getting that information out using AI, I think, is a promise that we have, and the same in post acute care settings like nursing homes or rehabilitation hospitals and chronic disease management. I mean, the list goes on and on where we can use these solutions.
Yeah, I only did 1 year of clinical medicine my intern year, but those were the bane of my existence. Going, it's like someone's on hospital day 86 and you gotta do your discharge summary, and it's like, "Oh god, I'm gonna be." Yeah, you just took over a service. Yeah, exactly. No, I mean, I think that's gonna be so valuable and save so much time, and that is a huge source of burnout, I think, for clinicians, is just, like, the amount of just, paperwork you have to sift through and then synthesize in your head what's important, making sure you're not leaving this medication change off and that medication. Oh, when did we increase this, increase that? So I think that's a great point. I mean, I think it's really going to help people. One of the questions I was going to ask you, and we ask this to pretty much every guest, you've had a really unique, career throughout medicine, coming from nephrology, going in hospital admin, and now you're kind of entering the most, I think, probably, exciting time to be in healthcare. And you're going to be like really weighing in on these decisions. So throughout your journey, what is one thing throughout life, medicine, your whole career that really rewired the way you thought about this whole thing and influenced your path?
You know, I I'll mention 2, but I'll focus on 1. The first is when I started to get involved in hospital committees, and it sounds like something trivial, but it made me realize that, say, wow, as good as I am, or as good as I think I am perhaps, I'm only influencing care 1 patient at a time. That's my limitation as a clinician right now. Perhaps I could broaden my influence through teaching and education, but it's really 1 patient at a time. Whereas if I take a step back and, work through quality at a hospital or a health system level, you have the ability to touch a number of lives. You can, shape protocols and decisions that can affect hundreds of patients instead of a single patient. And so So that really changed the trajectory of my career and my mindset. But the one I'd like to focus on is the one I briefly touched on earlier, and that is, when I began to realize the promise of AI in healthcare. As I mentioned briefly, when I get a CT scan of the abdomen, I recognize that it's providing me information that I don't have, but I see it as an extension of physical abilities I don't have. I just can't get that information. But when I saw how AI could think for us, it just changed the way I looked at healthcare. And I said, wow, you know, in the past, physicians often thought of themselves as subject matter experts. You know, Nurses are often spending more time with patients and connecting with patients than we are. Our expertise, our unique skill set, our core competency has always been on subject matter expertise. And I think with AI, subject matter expertise is still going to be important, but our empathy, our ability to connect with patients is going to come back as our core competency as providers. You know, that's something AI can't do, or at least currently. And so our ability to really listen to patients, to gather those inputs effectively, so we're feeding the right inputs into our AI models to make patients feel comfortable, to explain to them what the treatment plan is, to provide empathetic solutions because we now have the time to do so. All of that is, within our reach. And the day I saw these AI solutions provide, critical thinking, synthesize information that I had at my disposal, but it was doing it better than me. It was picking up stuff that I hadn't picked up on. And I'm looking at this patient and saying, how can this patient decompensate? I don't get it. They look great. But the AI model was picking up on stuff I couldn't pick up on. That really changed my perspective on the direction healthcare is going. And I said, wow, this is the real deal. And I still run into administrators in healthcare who think, that AI might be a fad or they're sitting on the sidelines. And I'm like, which rock are you hiding under? This is where regular technology was in the past. It was just on the peripheries. We had, computer-based solutions maybe for our billing and, scheduling and stuff like that. But then it became electronic health records. Then it became the robot in the OR and how vital signs are transmitted. And it's permeated every phase of healthcare delivery now, right? AI is going to be the same. Right now, it's in certain spaces. It's in the radiology space, it's in the clinical coding and documentation space. But there's no reason why it shouldn't be in just about every phase of the patient's healthcare journey, start to finish, in some way, shape, or form. There's still going to be a strong human element, but we will be more efficient and better and less prone to errors using AI solutions across the healthcare delivery spectrum.
Wow, that's a great summary of what we were kind of talking about, of just how this thing is rippling out and affecting everybody from all the patients and clinicians. And for all you medical students and stuff out there, it sounds like there's good times ahead where you're going to be able to actually spend time with patients again and make high level decisions based on a lot of information. This has been so helpful, Dr. Kumar. Thank you so much for coming. We really appreciate it.
Yeah, thanks, Vivek, for having me. It's been great. Thank you.
So, on today's episode, we discussed how artificial intelligence is moving outside of the radiology sphere and affecting healthcare as a whole in different specialties. We also talked about how it's super important for all of these specialties that are using new AI tools to have support from administration and to have good communication lines between the specialties that are using them. Our guest, Dr. Kumar, went over some of the key indicators that an administrator will look at when looking at whether an AI is helpful or not, and emphasizes the importance of return on investment in artificial intelligence. Stay tuned for next episode, where we move beyond just the AI ripple here and now and look at the future applications of AI. We're going to talk about genomics and preventative care and really what AI will look like in the next 15 years and what doctors will be able to do in the next 15 years with this exciting technology. Like, share, comment for more. Please share this with someone who thinks radiology or radiology adjacent fields are interesting, and please come back for next week's episode.